Okay, on to some miscellaneous information. So effective TR is 60,000 divided by heart rate. So 60,000 with an 80 beats per minute will give you 750 milliseconds. Next, to calculate the available imaging time in cardiac MR, you do the effective TR minus the delay and the trigger window combined. So for an 80 beats per minute, trigger delay 50 milliseconds. Trigger window is usually a percentage, so 10% here. For 80 beats per minute, you do the first calculation, 60,000 divided by 80 to get 750. Then your trigger delay is 50, and then 10% of your trigger window is 10% of 750. So 750 minus 125 is 625 milliseconds, total available imaging time. Contrast enhancing items here. So gadolinium is paramagnetic, multiple unpaired electrons. It reduces T1 times, which brightens them, and slightly reduces T2 times, so darkening them. Gadolinium enhancing pathology include tumors, infection, acute infarct, inflammation, and lesions. In the brain, structures will be falx cerebri, choroid plexus, pituitary, pineal, and infundibulum. In the spine, it will be the discs, scar tissue, and bone pathologies. And in the body, it will be liver, kidneys, spleen, pancreas, adrenals, and vascular. Super paramagnetic, or T2 enhancement, they shorten the T2 and darkens them. So for example, iron oxide is a super paramagnetic contrast agent used in liver imaging, and this includes ferrum oxide. Manganese is a T1 contrast for liver imaging again. Normal liver will enhance, but lesions will darken. Hyperpolarized helium is in T1 ventilation for lung studies. Oral is uncommon, but these used to include pineapple, blueberry, and mango juice. They are positive T1 and negative T2 contrast agents. Spatial saturation pulses are additional 90 RFs with wide transmission bandwidth to saturate all tissue. Place over unwanted anatomy inside and outside the field of view. It does increase tissue heating, SAR, and it will decrease your number of available slices. Gradient moment nulling, GNM, is also known as flow comp, or gradient moment rephasing, and it compensates for first order or laminar flow. It's a bipolar application of a gradient which rephases flowing spins and enhances the signal. For axial, it will use the slice select gradient, and coronal and sagittal, it will use the frequency encoding gradient. Next is chemical suppression. Uses an extra 90 with a narrow transmission bandwidth at the positional frequency of fat, water, or silicon before the alpha pulse. This will suppress tissue in an entire volume. Shims are helpful over the anatomy to improve homogeneity so that the fat, for example, will precess at the same frequency. Sat-TR is the time between the 90 saturation pulse and the alpha. It needs to be short to reduce additional T1 relaxation in this time. An equation here, Sat-TR equals your TR divided by your slice number. Stir is short TI. It's an inversion. It'll use about 100 to 175 to null fat. Flare uses the long inversion time of 1700 to 2200 to null CSF signal. Steady state sequences have residual transverse magnetization, RTM. There's 2 excitation pulses with variable flip angles. This is when the TR time is less than your T1 or T2 time. So the three types here. Coherent gradient echo is a steady state. It samples both the gradient echo, free induction decay, and the stimulated echo. Stimulated is the residual transverse magnetization. Coherent gradient echoes use rewinder phase encoding gradients because you can't transmit and receive an RF, and they're usually T2 star. Incoherent or spoiled gradient echoes are a steady state. Only the free induction is sampled. It dephases or spoils the stimulated echo. They're usually T1 or proton density. Steady state free precession. Only the stimulated echo or residual transverse magnetization is sampled. It uses rewinder phase encoding gradients again. Gives you a truer T2 image. Echo planar imaging, EPI, are gradient echoes. A constant oscillation of the phase encoding gradient. It fills all of K space in a single TR, filled linearly, line by line, in a stair-stepped fashion. They are fast, but distortion and chemical shifts are an issue. Different contrast can be achieved by the following. There is spin echo and gradient echo EPIs. Spin echo has the 90 and the 180 RFs, rephasings, and then a pulsing phase encoding gradient, which helps to eliminate magnetic inhomogeneities, whereas a gradient echo EPI has no 180. It's the shortest scan time, but the worst image quality. Different types of K-space, so centric, these are used for MRA or MRVs. You linearly fill from the center outwards. Uses shallow gradients first, which are mapped to the center for the contrast. And then steeper gradients going outwards, used in fast gradient echoes. Spiral, start in the center and then spiral outwards, using the phase and frequency encoding gradients. Two types are elliptical, which demonstrate arterial flow and suppresses venous, and propeller, which are motion suppression. Next is keyhole, which K-space is filled linearly. The outer lines are filled first before you give contrast, and then the inner are filled after the contrast. These are used during dynamic angiography studies. In geriatric patients, you want to reduce your VENC. Time of flight. Stationary spins give higher signal. They receive the excitation and rephasing pulses. Moving spins leave the slice before being rephased. So velocity of flow. As the velocity increases, time of flight effects increase. High velocity signal loss. If the velocity decreases, time of flight decreases for flow-related enhancement. If you increase your TE, increase your time of flight. If you increase your slice thickness, you decrease time of flight. 2D time of flight is for larger areas with slower blood flow. And 3D time of flight is for smaller vessels with high velocity blood flow, for example, the circle of Willis. Some general parameters here. So for conventional spin echoes, T1, short and short, so 300 to 700 milliseconds for your TR, and 10 to 30 for your TE. Your T2 is going to be a long and long, so 2000 plus and 80 plus. And proton density is a longer TR 2000 and a shorter TE of 20. That's conventional. For fast spin echo, T1, similar TR, but your T2 is going to be the shortest available. T2, again, a long TR, and a long effective TE, 80 to 140. And proton density along TR, 3000 to 10,000, and the shortest TE. For your conventional gradient echoes, T1 again short and short, so a lot shorter this time, 50 milliseconds, 1 to 5 milliseconds T2, TE. But a large flip angle to get T1 contrast. T2, I'm going to get a long TR 200, a longer TE 15 to 25, and a small flip angle 5 to 20. Proton density, a long TR 200 plus, a short TE 5 to 10 milliseconds, and a small flip angle. And next is just a bunch of random information that I put together from questions. So, vertebral arteries are not part of the circle of Willis. Vertebral arteries come from the right and left subclavian, but the right common carotid comes from the brachiocephalic. Diencephalon is thalamus and hypothalamus. Seventh cranial nerve is associated with Bell's palsy. The temporal lobe is commonly imaged for seizures, best seen on the coronal plane. Pituitary gland is best seen on coronal and sagittal. Intervertebral discs, the oblique axials. Vertebral arteries join to form the basilar artery. Internal carotid supplies blood to anterior brain. External carotid supplies blood to the face. And vertebral artery supplies blood to the posterior brain. Paramagnetic have magnetic moments less than 1, and ferromagnetic have magnetic moments greater than 1. If you double the receiver bandwidth, you lose 40% of the signal, and halving the receiver bandwidth, you gain 40. Decreasing the receiver bandwidth will increase the minimum TE. This can be an issue for where you want T1 for a short TE. Parallel imaging has the acceleration R factor. Decreased scan time, decreased noise, but increased aliasing. Sylvian fissure divides frontal and parietal lobe from the temporal lobe, and the middle cerebral artery passes through the Sylvian fissure. There's 12 cranial nerves total. Non-maleficence is to do no harm. Res isper loquitur, the thing speaks for itself. Informed consent is required for all procedures. You should pour sterile solutions from 6 inches. For negative pressure airborne rooms, you should have 6 to 12 air changes per hour. Flu is droplet precaution. Ataxia is difficulty walking. Aphasia is difficulty speaking. Auscultation measures respiratory rate. Temperatures, oral is 98.6. Axillary or tympanic 97.6. And rectal 99.6. These are all 0.6. So there's 97 for the axillary, 98 oral, 99 rectal. Objective measurements are signs. So these are rashes or temperatures, things you can actually see. Subjective are more feelings-based, so pain or dizziness. Signs and symptoms. You have, for heavily sedated patients, you need an EKG and a pulse ox. For mildly sedated, you can use a pulse ox. For conscious sedation patients, this can reduce respiration. Capnometer measures CO2. Claustrophobia affects around 5% of the population. For your BLS, it's now CAB, circulation or compression, airway, breathing. 8,200 compressions per minute. 1.5 to 2 inches of compression in the lower 1/3 of the sternum. You should do 30 compressions and 2 breaths. For arterial bleeding, you should put pressure directly on or proximal to the wound. And for venous, it should be distal or directly on. Gadolinium cannot pass the blood-brain barrier, but for breakdowns in this, it can get through and enhance, for example, tumours. The ventricles do not enhance post-gadolinium. So again, super paramagnetic have a negative effect on T2 to darken them. It will shorten the T2, iron oxide in the liver, ferrum oxide, hyperpolarized helium agents, T1 ventilation to evaluate the lungs. Oral is the juice, positive T1, negative T2. Compartment syndrome is extravasation of large amounts of contrast, which will increase pressure around the tissue, compartment syndrome. Renal function is bun and creatinine. Hepatocellular disease, you should have a GFR within 24 hours. 6 weeks for all others. 1/4 inch of insulation or padding around the patients are needed. Only level 2 can enter zone 3 unsupervised. Electromagnetic is for active shielding and located in the cryostat. Steel plates are for passive shielding in the gantry. For RF frequencies below 100 MHz, 90% of absorbed energy from the tissue is in eddy currents, induced by magnetic component of the RF field. Antenna effect are burns from conductive loops or coils and cables. The first law of EM, electromagnetism, is Faraday's law of EM induction. The second law is Lenz's law, which says an EM-induced current creates a magnetic field opposing the magnetic field that produced it. That opposing field is the eddy current. It will prevent your total efficiency in gradients and RF coils. Superconductive electromagnets are made from niobium and titanium. A cryostat is also known as a dewar. These are steel tanks that house the magnetic coils and cryogens. Permanent magnets are made from alnico, aluminium, nickel, cobalt. You have diamagnetic, paramagnetic, superparamagnetic, and ferromagnetic, then non-magnetic. Transceiver coil is transmit and receive, for example, the body coil. A volume coil is a transceiver for large volumes of tissue, but you have poor signal to noise. Transmit bandwidth is not adjustable at the MR console. A pulse profile is the visual representation of the RF pulse received by the MR system. So Faraday cage is copper in the walls to keep the outside RFs out. And again, passive shielding is steel in the walls or gantry to contain the fringe field. The time varying magnetic fields are the gradients. Slew rate describes the speed and strength of the gradient. So the frequency of hydrogen is 42.6 and at 1.5, 63.8. Low energy protons are spin up or parallel. The T1 of water is about 2,500. So T2 prime is a dephasing of spins due to inhomogeneities. So T2 star is the result of T2 and T2 prime. The net magnetization vector is also known as M0. In a traditional scanner, you have a vertical XY, whereas open bores have horizontal XY. Horizontally across the bore is the X gradient. Spatial encoding task is in slice selection, phase encoding, and frequency encoding. Gradient echo does not use a slice select gradient when you rephase the free induction decay, the frequency encoding gradient non-selective. In slice select gradient, the gradient slope controls your slice gap. Axial slices use the Z gradient. The phase encoding gradient the phase encoding gradient is switched on after the alpha pulse, but before the RF rephasing. Slope and polarity of the phase encoding gradient determines which lines of K-space are filled during the readout. The frequency encoding gradient is applied during the collection of the echo. So aliasing is more likely with a large coil and a smaller field of view. Cross-excitation is compensated with a 30% gap space and interleaving slices. Cross-talk is in the lumbar spine when there's slices in common. Moire is only in the gradient echoes due to undersampling. Parallel imaging artifacts are fixed with reducing the R factor and using calibration scans. Magic angles is when collagens are 55 degrees. You can fix it with altering the angle of the body part or lengthening a TE slightly. Your center frequency QC detects off-resonance operation. Your field of view has the biggest effect on your signal to noise. Acquisition time is your time to fill K-space. T2 star decay is also known as susceptibility decay. As your TR increases, your contrast to noise resolution increases. And same for TI, contrast CNR increases. TI does not affect acquisition time, possibly. TR does not affect TE. TI has similar effects to TR. That was just my note. Flip angle does not affect acquisition time. ETL does not affect spatial resolution. Effective TE does not affect scan time. Gradient moment nulling is also known as flow comp to compensate for first order laminar flow. It's a bipolar application of the gradient to rephase flowing spins. And axial images will require the slice select gradient. There's one way to remember that. Coronal and sagittal require frequency encoding gradients. SAT-TR equals your TR divided by slice number. Trigger window is in the last 10% of the RR interval. So if you have a 1000 millisecond, the trigger window is at 900, lasting 100 milliseconds. Peripheral gating prevents motion in extremities, including CSF, using the pulse ox. So, if you have TEs in multiple of 2.1, this is your Dixon. This will give you outer phase fathom water with dark outlines. But to get rid of it, you'll use TEs in multiples of 4.2. 4.2 fathom water are in phase, gives you the bright outlines. Both of these are gradient echoes. A rectangular field of view. A phase field of view is smaller than the frequency field of view. It maintains your pixel size and number of frequency encodings. It's achieved by undersampling. Conventional spin echo. A slow K-space filling, so usually T1 images. Driven equilibrium Fourier transform. A fast spin echo using reverse flip angle excitation pulses, so there'll be a 90 at the end, 90, 180, 180, 90. It drives residual transverse magnetization into the longitudinal axis or plane, so it cannot be excited again at the next TR. Gives you a hyper intense fluid signal and quicker T1 times. For stir, your TI will be 150 to 175, that's fat, at 1.5. Flare 1700 to 2200. Here's some questions. T1 gradient echo needs a large flip angle. Here's some questions you can look at, which I personally got wrong. Look at that. So incoherent, coherent, and steady state free precession are all steady state pulse sequences. Incoherent only samples the gradient echo of free decay. Uses RF spoiling and gradient spoiling. RF spoiling via digitized pulses. Gradient spoiling can be accomplished through all three gradients. Incoherent obtains T1 and proton density. Coherent samples both the gradient echo, free induction decay, and stimulated echo, residual transverse. It has rewinder phase encoding gradients, usually T2 star. Steady state free precession only samples a stimulated echo RTM. K-space filling type, so elliptical, shows arterial flow and suppresses venous. Diffusion, pathology is bright and normal tissue is dark. ADC is the opposite. Pathology is dark, normal tissue is bright. MRI can visualize arteries and veins. Time of flight refers to stationary spins, so a longer TE means more are moving, have left the slice. So stationary spins, time of flight increases. Time of flight uses incoherent gradient echoes. Carotids are 2D time of flights, and circle of Willis are 3D time of flights. High venk is for fast flowing blood, small vessels. And low is for slow moving, large vessels, for example, the femoral artery. Isotropic diffusion shows grey matter better, and anisotropic is better for white matter. So for diffusion, you first obtain diffusion maps, but these contain T2 shine through. So you then apply ADC mapping to distinguish stationary from T2 shine through. So basically an ADC eliminates T2 shine through, because T2 shine through can be confused with pathology on diffusion trace images. Low perfusion means pathology. So diffusion T1, so high perfusion or normal is bright. Low perfusion, pathology is dark. And these are opposites, so on diffusion T2, high perfusion, normal are dark, and low perfusion pathology is bright. Ischemic stroke are caused by a thrombus or embolism. Hemorrhagic is caused by a vessel rupture or bleeding in the brain. IV bag is hung from 18 to 24 inches above the IV. Gadolinium has multiple unpaired electrons. Paramagnetic agent. Positive local effects on the local magnetic field to shorten the T1. Contrast with stage 1 or 2 kidney disease is okay. Stage 3 is a risk versus benefit decision, and stage 4 or 5 kidney disease is often contraindicated. The AC foster vein, so cephalic is on the radial side, basilic is on the ulnar side, and the median cubital is between the two. Sorry about the spelling. Okay, that's it for now.